I'm ready. We're recording.
Yeah, I was gonna say we can just leave it.
Am I in it?
You should check.
Actually, now that the recording, I think it's been saved.
We can edit it.
Yeah, we'll edit it, we'll edit it.
What?
And if you just stay in that booth the entire time, you're the AV person.
Okay, I'm ready.
Alright, we're recording?
Are we all in this?
Okay. Alright, so today we're going to talk about posterior shoulder dislocations, specifically the reverse heel Sachs and how it affects our management decisions. So I'll start off with a little history lesson, go through the anatomy, the mechanism of injury, physical exam findings, fluid reduction techniques, and the outcomes of both non-op and surgical management. So posterior shoulder dislocations, they were first described by Sir Astley Cooper in his seminal work titled The Treatise on the Dislocations and Fractures of the Joints. In his book, he reported on 7 cases of dislocations of the os humeri and the dorsal scapulae. The mechanisms of injury described in this book were varied. They included a fall off a horse, being pulled down by a calf, and an epileptic fit. So 6 out of 7 of these patients were closed reduced successfully without any form of anesthesia. The one unsuccessful reduction of a posterior dislocation was confirmed when the patient died 7 years later, and they did a postmortem autopsy and they found the shoulders up the back. So we've learned a little bit more about posterior shoulder dislocations since then. We know it's a rare injury pattern, represents about 2 to 5% of all traumatic shoulder dislocations. It's 15 to 21 times more common than anterior dislocations, and the diagnosis is often missed or delayed in up to 79% of cases due to subtle radiographic findings, which we'll go into more detail later. The mechanism of injury in this video is not playing anymore. It's actually now consistent with the posterior dislocation. He had a posterior directly blow on an abducted and externally rotated arm, but I thought it was a cool video, but it's not playing anymore. So a little about the shoulder anatomy. The glenohumeral joint is relatively unconstrained, which allows for extreme range of motion about the shoulder, as demonstrated by the street performer. He's a member of the crew, triple jointed crew. Stability of the joint is conferred by both static and dynamic elements, which allow the shoulder to have large degrees of freedom while maintaining continuity. Going into more detail about the anatomy, the static stabilizers of the glenohumeral joint include the concave shape of the glenoid, the pattern of cartilage deposition on the glenoid, which is thicker on the periphery and thus increases the glenoid cavity. We also have the glenoid labrum, which serves as a 360 shock block restraint for chemical motion on the glenoid. Then we have the glenohumeral ligaments, which confer stability to the joint in differing arm positions. So the coracohumeral and superior glenohumeral ligament prevent posterior displacement of the head in a flexed, adducted, and internally rotated position. And the IVHL serves as the primary posterior stabilizer with the arm adducted. Dynamic stabilizers of the shoulder include the rotator cuff muscles, which by crossing the joint create a concavity compression effect. And it's the balance between the anterior and posterior cuff muscles that centers the head on the glenoid. Other posterior dynamic constraints include the posterior cuff, the biceps tendon, and the deltoid. So we're all taught in med school that electricity or seizures are associated with posterior shoulder dislocations. So the video here shows the strong muscle contractures that electric shock can produce. So Shaw and JBS in 1972, he characterized the pathoanatomy of a posterior shoulder dislocation that's caused by electricity or seizures. So a forceful contraction of the pec and the lat overpowers the weaker external rotators of the shoulder, which then forces the arm into internal rotation, with the head being forced medially and posterior, resulting in a posterior dislocation. So posterior shoulder dislocations can also occur with high energy trauma, when the arm in an adducted, flexed, and internally rotated position, which you can see here. And this is a retrospective review done by Robinson and colleagues. It was published in JBS in 2011. It sought to characterize the epidemiology of posterior dislocations. So they looked at 120 dislocations in 112 patients. They found that the majority, 67%, occurred secondary to trauma, 31% caused by seizure, and only 2% due to electrocution. All right, so moving on to clinical evaluation. So physical exam findings are important because the patients may be unable to provide an adequate clinical history, i.e. if they're drunk or if they're in a post-ictal state. The shoulder is often internally rotated with the prominent coracoid, and there's often posterior fullness in the axilla. There's usually a block to external rotation as the reverse heel Sachs becomes engaged with the posterior glenoid rim. Additionally, with that external rotation, you can get subtle diminished supination of the forearm. There's also a variety of posterior instability tests, including the jerk test, the posterior load and shift, and the posterior drawer. These aren't so much useful in the acute setting, but are more useful in in the chronic recurrent disability patient that you see in the office. So post-review imaging studies is really important in these patients with injury mechanisms that are suspicious for posterior dislocation. McLaughlin was one of the first surgeons to deal with these injuries, and he said they were sufficiently uncommon so that their occasional occurrence creates a diagnostic trap for the unwary surgeon. So in all these patients, you want to get a standard shoulder trauma series, an AP and scapular plane, a wide view and an X view. Axillary view is obviously the most important. You want to get a perpendicular view of the joint to see if the head is reduced. Velpo is also useful if the patients are in too much pain to abduct. There are a number of described radiographic signs that have been associated with posterior shoulder dislocations. So on the left, the arrows point to the trough sign. That's a linear area of sclerosis within the head, which represents collapse of the subchondral bone within the Hill-Sachs defect. The middle image shows a large reverse Hill-Sachs defect, and the image on the right is the light bulb sign because the humerus is blocking internal rotation. So to the untrained eye, the images on the left and right might look okay, but they're not, so you gotta make sure you closely scrutinize these x-rays. Advanced imaging is also important in all these patients. CAT scans are useful for both pre-op assessment of associated fractures, and they're also used to measure the size of the reverse Hill-Sachs, which has important implications for treatment. Thin sliced axial cuts are best for defining the extent of the defect. MRIs can also help define associated capsulolabral and rotator cuff injuries, and while they're not routinely used in the acute injury setting, in cases of irreducible dislocation, they can aid in the identification of the blocking structure, which is most commonly from rotator cuff tissue, a pulse capsule, or the biceps tendon. So there are a number of ways we can classify these injuries, sort of similar to Zuckerman conference on the left. You have anatomic descriptions, so subacromial versus subglenoid versus subspinous. You can get traumatic versus atraumatic, primary versus recurrent, etc. And then in 1994, this guy Heller created this etiologic classification that tries to incorporate a lot of these descriptions on the left, but as you can see in the table, it's pretty cumbersome and it's not routinely used in clinical practice. There are two classifications that you know about for posterior dislocation. The first is chronicity, is the injury acute or chronic. There's really no true consensus in the literature when an acute posterior dislocation becomes chronic, but most authors say it's around 3 to 6 weeks. Now, the importance of timing of the injury has implications on both ER and surgical management. With these chronic injuries that have been out for a while, you want to be very wary about post-reducing them in the ER. The capsules all scar down, the humeral head is softened, and there's a risk for active fracture. Additionally, the longer the head is out, the greater the chance that the articular cartilage is shot and reconstructive options might become less favorable. The other important classification is based on size of the reverse Hill-Sachs. So Robinson in 2005, he published these size cutoffs, which are based on existing literature treatment options for posterior dislocations. So small is less than 25%, medium is 25 to 40%, and large defects are greater than 45 to 50% of the head articular surface. Now these numbers are somewhat arbitrary, but they are routinely used for pre-op planning. So just want to go over a little more about the reverse Hill-Sachs. So this is the essential lesion in a posterior dislocation. It's also known as the McLaughlin lesion or the Malpain lesion. It's an impaction fracture of the intermediate humeral head, which is caused by abutment against the posterior glenoid rim. And in a reduced posterior dislocation, the defect can engage the glenoid with internal rotation of the humerus, which leads to recurrent dislocation. So as I mentioned before, the size of the reverse Hill-Sachs defect, it dictates the surgical management, and numerous authors use these size guidelines to determine what operation they're going to perform for these patients. So I looked through a bunch of these papers trying to figure out how exactly they measure the defect, but none of them explicitly said it, so that seemed a little confusing. Then I came across this paper, which was published in AJSM in 2013, and this excerpt from the abstract sort of echoed my sentiments. So, to our knowledge, no standardized method for quantifying the size of the reverse Hill-Sachs lesion has been reported in literature, which is alarming considering that the treatment of choice is mainly determined by defect size. So they said in current practice, the extent of the defect is quantified by estimating the percentage of the impacted humeral head articular surface based on CT images, which results in potentially great risk of misestimation and mistreatment. So these guys then proposed a novel method of measuring the reverse Hill-Sachs using a best fit circle around the humeral head on coronal and axial CTs. They then draw a radial line from the midpoint of the circle to the defect edges, and that creates an alpha angle, which they propose as a replacement for simply eyeballing and guesstimating the percent of the humeral head involved. They also describe the beta angle, which measures the location of the defect in reference to the bicipital groove. And they can also measure the depth of the defect shown in the images on the right. So in this study, they reviewed 13 reversible Sachs lesions. The eyeballing estimation method was first performed by 6 reviewers and showed poor intra and intra-observer reliability, as one would expect. Their best fit circle method improved the intra-observer reliability to 0.88 and the intra-observer reliability to 0.81. So the authors proposed that this method should be used to estimate defect size. I think this measurement method it seems useful going forward. It seems pretty easy and can help standardize our measurement, but again, because posterior dislocations are so rare, I think it's going to be tough to get clinically meaningful info. I.e., is there a cutoff angle, alpha angle, where you can recommend non-op treatment, or is there a defect with a certain beta angle that should definitely be treated surgically? I think it's going to be hard to get those type of conclusions. All right, so moving on to closure reduction techniques, there are a number of different ways to reduce a posterior dislocation that have been described in the literature. Again, because the injuries are so uncommon, there's not a whole lot of data with success rates of the various maneuvers. Robinson in 2011, he reported on 112 patients where closure reduction was attempted with gentle inline traction, but this was only successful on 33% of patients. Other techniques include the Stimson method, which we're all familiar with, the Ferris method, demonstrated here by Brian Park on Chris Lewis, where you use short vertical oscillations and slowly abduct the arm, and that somehow gets the shoulder back in. Two interesting methods I found were this German method, where you have a patient like supine, place one hand on the chest wall, and then use the other hand to pull traction and lever the humerus laterally using your arm as a fulcrum. And then the picture on the right creates another lever method. Again, the key maneuver being its laterally directed force, which theoretically helps disengage the L-Sachs and allows for reduction. So there's one other technique I want to mention. It's called the single operator reduction of posterior dislocations of the shoulder, the Sorpots method. This is something I came up with on call at Jamaica as a 2. I had a guy with a posterior dislocation and an ipsilateral perilunate dislocation, which was not annoying. So I'm collecting patients, but thus far had I think 5 patients with a simple posterior dislocation and 1 with a fracture dislocation. And thus far it's been 100% successful without general anesthesia. So if you guys have a posterior shoulder, use this technique and tell me about it. So first step, this is Dr. Patel playing a patient with a right posterior dislocation. So you want to put the patient in the lateral DP position, affected side up on the stretcher. You then want to gently forward flex the arm about 90 degrees. So the theory behind that is that most reversible Sachs are vertically oriented. So moving the arm to the forward flex position places the defect perpendicular to the glenoid rim and increases the chances of successful reduction. You then can place one arm against their chest wall, and then with your other arm, you want to lock elbows anacube to anacube. And at this point, you can stabilize their torso with the arm against their chest, and then you lean backwards, creating inline traction with the humerus. So while you're doing this, you can also lever your arm up to the ceiling. This is going to provide that laterally directed force that helps with L-Sachs disengagement. And then finally, by internally rotating their arm, they're going to externally rotate their arm, and the shoulder pops back in place with the next one. An additional step you can do if the head is perched on the back of the glenoid, you can reach around the back of their shoulder and sort of milk the head back all the way in. So again, try this technique if you guys have posterior dislocations. All right, so let's say you get a consult for posterior dislocation, you reduce it, you get your CT scan. What's the next step? Now, is there a role for definitive non-op treatment for these patients? So I would say yes in certain selected ones. These are 2 studies looking at posterior dislocations treated non-operatively. The first was published in JSES in '98. They had 73 posterior dislocations, 9 were managed non-op. The criteria for conservative treatment included a head defect less than 20%, patients with less than 4 weeks out from injury. All patients were closure reduced, and then they were mobilized 4 to 5 weeks in 20 degrees of abduction and 30 degrees of external rotation. So this is the position of stability of posterior dislocations. It prevents L-Sachs engagements and allows the posterior capsule and other soft tissue to spread out. So they followed patients for 22 months. The mean UCLA score at final follow was 34 out of 35. And the range of motion was equal to the contralateral side. Next study, again out of JCS in 2007, 7 patients produced within 14 days of injury. Defects ranged anywhere from 18 to 32%. Again, immobilized in position and stability. They followed them for 46 months, only 1 recurrent dislocation, and then the average ASES score was 93.5 at final follow-up. So good outcomes can be attained with conservative management and appropriately selected patients that have small head defects, immobilized for 4 to 6 weeks of position stability, and then slowly rehab from there. The other candidate for non-op treatment is an elderly patient with a chronic dislocation. So despite anatomic deformity and severe loss of rotation, these chronic dislocations can be surprisingly well tolerated. So you can treat the non-op for elderly, low demand, with minimal pain and a functional range of motion. So this guy in the picture here had a posterior dislocation on the left. You can see he can get his hand up to his mouth. And then Hawkins in JBDS in 1987 reported on 7 patients with untreated dislocations. Only 2 out of 7 of them were able to get their arm or their head, but their pain ratings didn't worsen over time, and the functional losses did not progress beyond the immediate post-injury loss. So in acute dislocations, if you can't get the reduction closed, you got to open it up. Isolated open reduction without complicated procedures can be successful in small-sided defects. So when you use a standard dental pack approach, the head lies deeper in the wound than usual. You want to open the rotator interval so you can get a finger in the joint, and that can aid you in your manual reduction. You can also go to the back. The incision is depicted here, and then joint access can be achieved with either an infraspinatus sternotomy or going between infra and teres minor. So arthroscopic aided reduction has also been described. This is a paper out of Rush, case report of a 26-year-old male with a 4-week-old posterior dislocation and 20% Sachs. So they put a switching stick in the posterior portal and placed it superior and medial to the head, resting on the anterior glenoid, and then with lateral and distal traction in the arm, they levered it using the glenoid as a fulcrum. So in this patient, they scoped him right afterwards. They repaired the posterior bank guard, and then 4 years post-op, did no recurrent instability and full canvas range of motion. All right, so patients with small defects, we know they can be managed successfully non-op, but what do we do with medium-sized defects? So there are 2 described procedures, the McLaughlin and modified McLaughlin. So McLaughlin published a series of posterior dislocations in 1952. He had 22 patients in the series, 5 of which were treated surgically with what would become known as the McLaughlin procedures. So he went through a double track incision, he did a transverse subscat split, and then the humeral head was levered back into the glenoid. He noted that with the large defects, even the slightest bit of internal rotation and flexion, the defect would engage and then re-dislocate, unless the defect was filled with an object of sufficient size. So he found that the end of the subscat tendon fit nicely, so he would freshen up the defect and then suture the end of the tendon into the defect with mattress sutures through the bone. He had variable follow-up on these patients, anywhere from 2 months to 4 years. Post-op, they were in a sling, swap, and pendulum exercises were started in the wounds to heal. They didn't really have validated outcome measures in 1952, so the results were described generally as satisfactory. Most could perform ADLs, and 1 patient was even back to golf within 2 months. So fast forward 20 years, another Columbia surgeon, Dr. Neer, he described a new method of filling the humeral defect using an osteotomy of the lesser and securing it into the defect with a screw. The rationale being that more secure fixation of the tendon was possible by preserving its native attachment. So this is a paper of 41 dislocations, 4 of which were treated with the modified McLaughlin. Indications were a 20 to 45% head defect, and patients had to be dislocated less than 6 months. They were immobilized in external rotation. Variable follow-up again, 2 to 9 years, but they reported at final follow-up, all patients had no pain, no limitations in ADLs, and 5 out of strength of the shoulder. So the modified McLaughlin is the most widely used procedure for medium-sized defects. This is a select review of outcomes for the modified McLaughlin, and results are generally decent. Finkelstein and JOT reported no recurrent dislocations. Spencer in 2005 again no recurrent instability. In the late 2000s, we started seeing some more meaningful outcome measures. So Castagno reported an inconstant score of 75 in final follow-up. Locales got an average of 84, and then most recently Shams found 81% for the excellent UCLA scores. So there's a couple problems with these results. Firstly, they're all small retrospective case series. Secondly, only short to midterm results reported. Lastly, and perhaps most importantly, the techniques used in all these papers are all varying modifications of the modified McLaughlin. So some authors use screws only, some use suture anchors in the defect, some use screws and suture anchors. So all these factors combined make it hard to glean meaningful evidence-based guidelines for treatment. And as you'll see in the next few slides, that's going to be a recurring thing when we look at the literature for posterior dislocations. All right, so what other options do we have? What if the hill sack's a little bigger and the subscap tendon doesn't quite fill the defect? This is a paper done by Gerber and colleagues, published in JGS in '96. They had concerns that the subscap transfer for moderate hill sac defects, they had a couple concerns. Firstly, that it's a non-anatomic reconstruction and they therefore has a theoretical risk for limiting internal rotation. And two, it can make future arthroplastic procedures more difficult. So they reported on the results of using allograft femoral head to fill the defects. They had 4 patients in their series. Indications for reconstruction were a 40 to 55% articular defect. The graft was contoured on the back table to restore the sphericity of the head and was fixed into the defect with countersunk tensile screws. Post-op, they were immobilized for 6 weeks. They had average 6 to 8 month follow-up. Average constant support of final follow-up was 82. They did have 1 case of graft AVN. This is a long-term report on that previous study. They included 18 more patients. 19 were available for long-term follow-up. Final average constant support was 77. 2 out of 19 did require arthroplasty, some 15 years after the next surgery, but based on these results, the authors concluded that segmental reconstruction for medium space defects does reliably restore stability and freedom from pain with an excellent subjective long-term outcome. Good results with allograft have been replicated in the literature. These are just 2 smaller, more recent studies that show results of allograft reconstruction. Both have medium-term follow-up and good final constant scores. Again, these outcomes are limited mainly by small numbers, so these results should be interpreted with caution. All right, lastly, moving on to large defects, greater than 40-50%. So this is a pattern of injury most commonly present in patients with early diagnosis or chronic injuries, and also in elderly patients with soft bone secondary to osteoporosis. The consensus in the literature is that arthroplasty is the best treatment for these patients because with such large defects, reconstructive options are at high risk of failure. So this is one of the first published series on the use of arthroplasty for the treatment of large head defects. So in Hawkins and Neer's series of 40 dislocations, 16 had a hill sac greater than 45%, with soft or non-viable articular cartilage that was deemed not suitable for subscap transfer. They did 9 hemis and 7 total shoulders. 3 patients in the hemi group had obvious glenoid wear, but they couldn't do a total because that wasn't invented yet at the time. In the hemi group, they had 2 to 14-year follow-up, 6 had good results, no ADL restrictions, no loosening on x-rays, and then 3 patients with no glenoid wear were eventually converted to a total shoulder. In the total shoulder group, they had 1 dislocation, otherwise all did fairly well.